Hello everyone and welcome back to my channel. This is Professor Asif Qureshi and you are watching Dr Asif Lectures. हम 10 teachers से gynecology कर रहे हैं और आज चैप्टर नंबर 4 डिस्कस करेंगे which is about the disorders of menstrual bleeding. अब ये बड़ा important chapter इस तरह से है because abnormal menstrual bleed is one of the very common presenting complaints in gynecological patients. So हमने स्टार्ट में जो चैप्टर्स किए हैं उसमें चैप्टर 2 में पर्टिकुलरली वी हैव टॉक्ड अबाउट हिस्ट्री एंड एग्जामिनेशन. सो वहाँ हिस्ट्री पे हमारी ये बात हुई थी कि मैनी ऑफ द टाइम एबनॉर्मल मेंस्ट्रुअल ब्लीडिंग इज द मोस्ट कॉमन प्रेजेंटिंग कंप्लेंट. सो फॉर एग्जांपल हमने ये वर्ड यूज किया था हैवी मेंस्ट्रुअल ब्लीड. सो हैवी मेंस्ट्रुअल ब्लीड इज ऑलवेज टेकन टू बी it always has to be taken seriously because it can be a symptom of some serious underlying problem. इसी तरह intermenstrual bleed है, bleeding between the menstrual cycle expected dates. There is postcoital bleeding. So these are all the disorders of bleeding which are always indicative of something serious and must be investigated. I mean, not always indicative of something very serious, but they can be indicative of something very, very serious. So it has to be always investigated. That is the rule of thumb. Now, the learning objectives of this chapter are that the participants by the end of this lecture should be able to understand the symptoms and etiology of abnormal uterine bleeding. ये general word use करते हैं AUB, which basically is an abbreviation for abnormal uterine bleed. We should be able to describe the terminology of abnormal uterine bleed और फिर इसके क्या-क्या examples हैं. You should be able to tell what are the different examples of AUB. You should also be able to understand the symptoms, investigations required, and management of heavy menstrual bleed. Now, heavy menstrual bleed is I would say it's an absolute red flag. जब भी if you are dealing with a patient with heavy menstrual bleed, always investigate appropriately because there may be something very serious underlying जिसका ये symptom हो सकता है. So appreciate the impact of HMB on the ability of function of the female reproductive tract. Obviously, understand the causes and investigations of dysmenorrhea. Dysmenorrhea is the painful bleed. ये भी हम आज discuss करेंगे. Then understand the action of medications used for menorrhagia and dysmenorrhea. So these are all the spectrum of learning objective that is expected for you to learn through today's session. They're all very important, and let us begin with the introductory paragraphs. Disorder of the menstrual bleeding. पहले ये वर्ड तो यूज हम करते थे, अभी भी करते हैं, डिसऑर्डर ऑफ मेंस्ट्रुअल ब्लीडिंग, बट द अप्रोप्रिएट वो कहते हैं ना डिक्शन परफेक्ट वर्ड है एबनॉर्मल यूट्राइन ब्लीड. So you should be able to understand because basically ये जो menstrual bleed है ये आ कहाँ से रहा है? This is coming from the uterine vessels, right? So it's coming from the uterus. So it's better to call it appropriately. So abnormal uterine bleed is the word that we use very routinely now, and this is scientifically correct. These are one of the most common reason for women to attend the general practitioner, and obviously हमारे setups में not all the women directly approach the gynecology consultant on the first visit. They usually go to their GPs first. So this is how it begins. And although rarely life-threatening menstrual disorders can cause major social, psychological, occupational upset, life-threatening abnormal uterine bleeds can happen, but they are not very common. However, females do notice if there is something abnormal going on, and they do visit their GPs. KG heavy menstrual bleed hai ya painful bleed hai, things like that, right? So this is something that females pick up very early on, and usually they consult. There are several types of abnormal bleeding and their terminology should be known. ये abnormal uterine bleed तो एक broader terminology है ना, तो इसमें uterine bleeds कई तरह के हो सकते हैं. So for example, there is a term called heavy menstrual bleed. अब आप कहेंगे जी इसको भी तो heavy uterine bleed होना चाहिए, बात सही है, लेकिन यही term अभी चल रही है. Intermenstrual bleed यानी एक डेट एक्सपेक्टेड इधर है एक इधर है और बीच में भी ब्लीडिंग हो रही है. पोस्ट क्वाइटल ब्लीडिंग इज द ब्लीडिंग आफ्टर इंटरकोर्स. पोस्ट मीनोपॉजल ब्लीडिंग यानी एक दफा थिंग्स हैव स्टॉप्ड बट नाउ देयर इज सडन रीस्टार्ट ऑफ ब्लीडिंग. दीज आर ऑल इंपॉर्टेंट टर्मिनोलॉजीज. ओके, सो ये सब आपको पता होना चाहिए. व्हाट इज HMB, व्हाट इज पोस्ट क्वाइटल ब्लीड, इंटरमेंस्ट्रुअल ब्लीड एंड पोस्ट मीनोपॉजल. Initial investigations for each include speculum examination, सब में करना है आपने, of the cervix. You should take swabs, cervical smears if indicated, and transvaginal ultrasound and endometrial biopsy as necessary. इन तमाम investigative approaches के बारे में हमने chapter 2 में already कर लिया है, तो आप मेरी second video देखिएगा, उसमें ये सारी details मौजूद हैं. Further to this, outpatient hysteroscopy and biopsy may also be indicated. All discussed already in chapter number 2 कि कैसे करते हैं, right? There are several classifications of abnormal uterine bleeding, some of which link symptoms to pathology, such as such systems help clinician to adopt similar categorization of pathology. अभी बताता हूँ इसका मतलब क्या है. एक system है which is increasingly recognized is known as the palm coin system. It is developed by the International Federation of FIGO से develop हुआ है, you know that, in which the mnemonic palm represents visually objective structural criteria. So polyps, adenomyosis, leiomyoma, malignancy. So this is the palm thing, right? So yani the female is presenting you with heavy bleed or abnormal uterine bleed. You do the investigation examination. You see either polyps or adeno or leo or malignancy. So that's the palm criteria. And then there is a coin thing, and this is for coagulopathy. कोई coagulopathy है, ovulatory disorders, endometrial iatrogenic, यानी कोई endometrial cause है, it can be anything, can be a tumor, can be a cancer, can be a benign tumor. Iatrogenic, कोई procedure किया था जिसकी वजह DNC for example किया, उसकी वजह से कोई problem है, and not classified. So these are all, you see the CO, ये इससे ये coin word निकाला है, ठीक है? Now, note that further description in this chapter for abnormal uterine bleed do not refer specifically to this system. ये आपको एक terminology throw की है इस chapter में कि आपको पता हो कि how do you basically classify. Medicine में या किसी भी field में it is very important कि जब भी कोई आप disease या कोई और अगर field है तो कोई एक system पढ़ रहे हैं, so it's better to systematically approach it. And in order to do so, many people love, devising such beautiful terminologies. ऐसे acronyms बनाते हैं, abbreviations बनाते हैं जो easy मेमोराइजेबल भी हों, थोड़े फैंसी लुकिंग भी हों, तो लेकिन ये अब हम आगे चैप्टर में ये खुद भी कह रहा है, मैं यूज नहीं करूंगा. इट विल सिंपली बी टॉकिंग अबाउट हैवी मेंस्ट्रुअल ब्लीड एंड थिंग्स लाइक दैट. इट्स नॉट गोइंग टू रेफर अगेन एंड अगेन टू पाम क्राइटेरिया. ओके. एबनॉर्मल यूट्राइन ब्लीड के लिए जो कॉमनली यूज्ड और एक्सेप्टेड टर्मिनोलॉजीज हैं वो थोड़ा तो मैंने आपको फ्लेवर दिया है कि व्हाट इज HMB. दिस इज एक्सेसिव मेंस्ट्रुअल ब्लड लॉस एंड दिस इज द फोकस ऑफ दिस चैप्टर, हैवी मेंस्ट्रुअल ब्लीड. ओके. Then there is intermenstrual bleed, which is the bleeding between the periods, often seen with endometrial and cervical polyps. Benign conditions of the uterus and cervix, also endometrium, they can all cause intermenstrual bleed. Obviously, I mean, if this is the date where you had the bleed and this is the date where you were expecting the next bleed, and you suddenly have bleed here, this is abnormal, right? Should not happen here. So there should be a cause for this. You have to look for it. Post-coital bleeding is bleeding during or after intercourse, and it's often associated with cervical abnormalities. So if the patient comes with, Janab, after sexual intercourse, I feel blood coming out, think of cervical abnormalities. However, other lower genital tract organs may be involved. Then there is post-menopausal bleed. Oh, it's a red flag. Exclude endometrial pathology, particularly endometrial cancer. This is very important. Okay, malignant disease is common. BEO is bleeding of endometrial origin. It's a diagnosis of exclusion where you cannot identify any particular cause. You just call it BO. Right? So these were the general concepts. Now let us talk specifically about heavy menstrual bleed. Heavy menstrual bleed is the most common type of menstrual bleeding disorder. It's a very common. And there have previously been some confusion over the various terminologies used for the abnormalities. HMB is now the preferred description as it is simple, easily translatable into other languages. Heavy menstrual bleed, simple to use, easily. It tells you what's wrong in the patient. It's heavy menstrual bleed. Okay, it replaces the older term which was menorrhagia. So basically, HMB is equal to what we used to call menorrhagia. In fact, in our medical school, when I was graduating, menorrhagia is the term that we used to use, right? but now it's been almost replaced by HMB. It is defined as a blood loss greater than 80 ml. I mean, obviously, if you are calling it heavy, you have to then quantify how heavy. More than 80 ml per period, यानी period 3-4-5 दिनों पर जो है उसमें अगर 80 ml से ज़्यादा blood loss होता है, then this is what you call it, right? In reality, methods to quantify menstrual loss are both inaccurate and impractical, and as a clinical diagnosis based on the patient's own perception of the blood loss. Now, this is a super important statement because see what it is telling you. अब मुझे एक बात बताएं, हम यहाँ बुक में लिखने को तो हमने लिख दिया कि blood loss more than 80 ml. Now, how many females do you know who actually quantify and measure their menstrual blood loss? I don't know a single woman doing this. कि वो क्या blood measure करते हैं? There's impractical, you can't do that, right? But then we have rough criteria कि जी कितने pads change हुए क्या. This is something जिसमें you have to rely on what patient is telling you. Patient will tell you that previously it used to be like this much number of pads I need to change. Now it's this much number. So I'm telling you, I feel this is heavy. You have to go with that, right? Of the women in reproductive age, 20 to 30% suffer from HMB. So this is very common. आप जरा देखिए ना, 20 to 30. हर 10 में से 2 या 3 लोग जो हैं उनको heavy menstrual bleed होगा. Each year in the UK, 5% of the women between 30 and 49 consult their GPs for HMB. So this is very common here. The etiology of HMB can be hormonal, it can be structural. अगर किसी को fibroids हैं, 30% of HMB patients they associated with fibroids. Adenomyosis, 70% of the women. Endometrial polyps. So this is a diagram to show you the polyps, by the way, right? These polyps. But the point is that HMB is very common. They present often to the clinics and you have to investigate. अब कैसे पता चलेगा fibroids हैं, adenomyosis हैं? Obviously you will do history, examination and some investigations, right? And the investigations will include ultrasounds and other modalities. So just be very careful. अगर exam में सवाल आता है, HMB is something not to be taken lightly, okay? There can be coagulation disorders in females such as von Willebrand, PID. Thyroid diseases can present with abnormal bleed, heavy bleed, drug therapies, particularly warfarin. Blood gets thin, you see here. Intrauterine devices, and more seriously, cancer. So there's a long list of if somebody asks you what are the common causes of HMB, there's a long list. But remember, I mean, these two would make most of them, right? Most of the heavy menstrual bleed is because of benign condition, particularly fibroids, adenomyosis, things like that. Other symptoms may be described in the history और भी symptoms हो सकते हैं. Let's have a look क्या क्या symptoms हैं. These are the associated symptoms with HMB. So heavy menstrual bleed के साथ ये हो सकते हैं. It can be irregular bleed. There is no fixed time period. These patients may also complain of intramenstrual bleed, postcoital bleed, history of PPH, for example, bruising. So this is for the coagulopathy, post-operative bleeding that may be because of coagulopathy, which is existing there, or warfarin therapy, bleeding with dental extractions, again indicating towards coagulopathy, vaginal discharge, abdominal masses, agar fibroids hain, weight changes, skin changes, if there are hormonal stuff, thyroid disease, right? So this is a good table, can be the associated symptoms. So basically in associated symptoms ko dekh ke you can actually chalk out the list of differential diagnosis. So for example, if a female is coming to you with a complaint of heavy menstrual bleed and she also is complaining of weight changes, skin changes, this may be a pointer toward an existing thyroid disease which is leading to heavy menstrual disease, heavy menstrual blood, okay? So it's always, this is why I always say that presentation, the clinical presentation must be accompanied by a very good history and a very good examination and very good and nicely asked laboratory test, and then you make a list of differential diagnosis. So as a good clinician, as a good physician, after the presenting complaint, the next very important thing is your history and examination. So you have to ask relevant questions, you have to reach to the diagnosis, and this table helps you a lot in doing so. What investigations you do, obviously it depends upon what you are thinking in terms of the disorder. So if you are thinking, for example, fibroids, if you are thinking, for example, thyroid disorder, so your investigations will be on those lines as well. So you would obviously do full blood count to see how the blood profile is looking. You would do coagulation screen, very important. Any bleeding disorder, you should do that. Hormonal testing, T3, TSH, for example. Pelvic ultrasound is a must because you are suspecting fibroids, which is very common cause of heavy menstrual bleed. Then high vaginal and cervical swabs. You should be doing ultrasounds as well. Thyroid function, in particular, biopsy sometimes is also required. There is an abnormality on, if you see abnormality on transvaginal ultrasound, which is amenable to treatment. If there are facilities, perform the resection, do the resection. So this is a ladder approach where you have the patient with, presentation, and after the presentation, you do the history and examination, and after history and examination, you order laboratory test, and after the labs, you just start treating the patient. So that's a kind of continuum. Okay, now the role of EB in heavy menstrual bleed patients. So let's have a look there. Outpatient hysteroscopy or EB is indicated if, this is an important thing to understand, right? क्योंकि अगर आप देखो एग्जाम में जो एग्जामिनर्स हैं, they are very interested if you are able to stratify your patients, कि which patient require what investigations, which patient require what treatment. This is very important, and therefore at many places in your medicine journey, you will actually be finding guidelines, indications. So for example, एक patient है, उसमें मुझे bypass surgery, cardiac bypass surgery की बात कर रहा हूँ, वो करनी है. So what are the indications? ऐसा तो नहीं है मैं किसी भी patient में कर लूँगा. There must be some indications कि अगर patient में ये हो, ये हो, ये हो, तब मैं bypass करूँगा. बिल्कुल इसी तरह कोई भी treatment आपने देनी है. For example, if you even have to prescribe antibiotics such as amoxicillin, so there must be some indications, right? You must be thinking, I am looking at gram-positive bugs, this is the bacteria I'm thinking, and hey, now start giving amoxicillin, for example. So बिल्कुल इसी तरह outpatient hysteroscopy की भी indications हैं. If the post अगर thickness transvaginal ultrasound पे 4 मिलीमीटर से ज़्यादा है, you consider hysteroscopy. अगर patient में HMB है and over 45 years, you consider hysteroscopy. अगर intermenstrual bleed भी है, heavy menstrual bleed के साथ, you do that. Treatment failure, treatment काम नहीं कर रही, you consider that. Prior to ablative technique, obviously you have to look by a scope how the uterus is looking. So in order to, ये नहीं कि हर patient में you do hysteroscopy, right? There are indications. These are the indications when you do hysteroscopy. Okay. So after you have done all the history examination, how do you manage the patient with heavy menstrual bleed? For some women, the demonstration that their blood loss is in fact normal may be sufficient to reassure them. So you have done everything, you don't find any problem, and you say that, well, bear with that, and it may come back to normal. For others, there are a number of different treatments of HMB which you may need to cater. So when selecting the appropriate management for the patient, it is very important to consider the patient's preference of the treatment. I mean, ये general rule है medicine का, जब भी आप कोई treatment या कोई investigation plan करते हैं, you should discuss this with your patient, right? This is very important. Unfortunately, practices में ये हो नहीं रहा होता. I have seen a lot of doctors doing this कि patient को बस ये दवाई ले लो, भाई बता भी दो यार इस दवाई क्यों ले लो क्या. तो consultation is very important, ethical consultation. So you have to do risk benefit of for each patient, discuss with patient, उसकी choices भी पूछें उससे, उनको उसके pros and cons बताइए, सब चीजें, right? And then contraceptive requirements, फैमिली कंप्लीट है या नहीं है, करंट कॉन्ट्रासेप्शन यूज कर रहे हैं नहीं कर रहे हैं, ऑल दीज कंसिडरेशंस आर इंपॉर्टेंट, राइट? कोई प्रीवियस सर्जरी तो नहीं हो रखी, एनेस्थीसिया से कोई प्रॉब्लम तो नहीं है, एंड ये सब कुछ केटर करके देन यू स्टार्ट managing the patient basically. Now management of HMB, there are so many different things, right? यहाँ टेबल बना दिया है, इनकी थोड़ी डिटेल्स भी हम देख लेते हैं. So sometimes you are doing managing the patient just on the contraceptive pills. Sometimes you have to use tranexamic acid, so or progesterone only pills, or sometimes ablation, you just burn out the blood vessels, sometimes hysterectomy or umbilical artery embolization. It all depends upon what is the pathology that you are dealing with, right? So medical treatments, for example, अब हम ये सब डिस्कस करते हैं जो यहाँ टेबल में चीजें दी हुई है ना, कि LNG-IUS है क्या, मेफेनेमिक एसिड या ट्रांसएक्सिमिक एसिड कैसे यूज करना है. So let's talk about them. These are all the medical treatments where you are doing something medically, obviously. Initial management is the absence of a structural or histological abnormality. So no structural, no histological, आप surgery नहीं करेंगे ना, आप उसको medically manage करेंगे. So the first one which is there is levonorgestrel intrauterine system. So this is what it is, LNGIUS, intrauterine system, and levonorgestrel, right? It's provided long-term use of at least 12 months. LNGIUS, trademark name Mirena, has revolutionized the treatment of heavy menstrual bleeds. So it's a very routinely and very successfully used drug. Mean reductions in mean blood loss of around 95% are achieved by 1 year. So that's a remarkable achievement, right? It provides a highly effective alternative to surgical treatment with few side effects, obviously. Indeed, the Royal College of OBGYN has suggested that LNG-IUS should be considered if majority of women as an alternative to surgical treatment. ये इतनी important treatment है कि is also being considered as opposed to surgery. Tranexamic acid, it is an antifibrinolytic that reduces blood loss by 50%, also very successful. Then norethistron taken 15 milligram per day in a cyclical pattern from day 6 to day 26 of menstrual cycle has also been very useful. Then GnRH agonist, these are the drugs which act on the central axis pituitary to stop the production of estrogen, and this then leads to amenorrhea. So you're shutting off the central system, right? But then there are better drugs available. All right. If medical stuff is not working, obviously you have surgical option, and sometimes this is required because if you have major structural problems such as fibroids हैं या God forbid cancer है किसी को, then you have to take these surgical options, right? Details of surgical interventions are particularly given in chapter 7. हम पढ़ेंगे इसके बारे में कौन कौन सी सर्जरीज करते हैं, what is hysterectomy, what is oophorectomy, सब डिस्कस करेंगे. But surgical treatment can be a treatment for heavy menstrual bleed, right? तो ये आपको इस वक्त इतना बस याद रखना है. Then there is an option which is known as ablation. Ablation is basically you are burning the blood vessels. So all endometrial destructive procedures employ the principle that ablation of endometrial lining. This is where the blood comes from, and this should be sufficient enough to stop the bleed and also to allow the endometrial regeneration. Ablation is suitable for women with a uterus no bigger than 10 week size and fibroid less than 3. इससे ज़्यादा है तो फिर सर्जरी करनी पड़ेगी यार आपको, तो ये बात याद रखनी है आपको, ठीक है? Right, the first generation techniques include trans-cervical resection. So through cervix you do that, and there is a second generation technique which include all these. Which is much more advanced system, obviously, as compared to the first generation. As a general rule, all women undergoing endometrial ablation should have access to a second generation technique. After treatment, 40% will become amenorrheic, बिल्कुल ही blood गायब हो गया for some time being, obviously. 40% will have markedly reduced menstrual loss, and 20% will have no difference in their bleeding. So 20% failure rate है ये आपको पता होना चाहिए कि this treatment is not 100% successful. In fact, any treatment for that matter. Umbilical artery immobilization कहने लगा था मैं, embolization, ये हम डिस्कस करेंगे चैप्टर 12 में काफी डिटेल में. मायोमैक्टमी, समटाइम यू रिड्यूस द चंक सच एज फाइब्रॉइड्स हैं, ये मायोमेट्रियम में डेवलप होते हैं यूट्रस की, रिमूव दैट. ट्रांस सर्वाइकल रिजेक्शन ऑफ फाइब्रॉइड, सर्जरी है. ट्रांस सर्वाइकल मिनिमली इन्वेजिव, रिमूव द फाइब्रॉइड. हिस्टेरेक्टमी इज ऑब्वियसली प्रिजर्व फॉर सिवियर डिसऑर्डर. सो चैप्टर 17 में हम पढ़ेंगे, लास्ट चैप्टर है ये, जिसमें हिस्टेरेक्टमी कैसे करते हैं, हाउ डू यू रिमूव द यूट्रस. Acute HMB, not infrequently, women are admitted to the hospital with acute abnormal uterine bleed. They require stabilization. Obviously, acute blood loss हो रहा है तो इनके ABCs आपने cover करने होंगे, airway, breathing and circulation. इनका क्योंकि blood loss बहुत ज़्यादा हुआ है ना, so maybe you need to give certain fluids to restore the volume status. And then you investigate why the bleeding is happening through all the techniques that we have discussed, and then you manage. Management of acute HMB, admit the patient, do the pelvic examination, do the blood screens, IV access foreign ताकि आप fluid administer कर सकें. Tranexamic acid immediately, transvaginal ultrasound to see what's going wrong. High dose of progesterone, this usually arrests bleeding. Consider this is now an immediate acute condition, so you have to take all the acute measure, even given the GnRH drugs, you suppress the central system immediately, and then you make a long-term plan कि क्या cause थी, कैसे investigate करना है, क्या treat करना है, okay? But first of all, you have to treat the patient जो acutely present किया है emergency room में. Dysmenorrhea is the next topic on list for this chapter. This is defined as painful menstruation, very, very common. It is experienced by जरा percentage देखिए 45 to 95% of women of reproductive age. कितना common है? यानी अगर दूसरे अल्फाज में कहूँगे in almost every other women or perhaps in every single woman there is experience of painful menstruation. During the menstrual cycle there is pain, right? Very, very common. Primary dysmenorrhea describes painful periods since the onset, यानी day 1 से हमेशा से जी painful है जब शुरू हुए थे तब से ही. And it is unlikely to be associated with the pathology. That's just normal kind of thing. There is some evidence to support the assertion that primary dysmenorrhea improves after childbirth. This is very commonly and routinely understood, and it appears to actually decline with the increasing age as well. Secondary dysmenorrhea, however, are the painful period that initially I was absolutely fine. There were no issues. My menstrual cycles were without pain, but now I'm having painful cycles. So this is something, there may be an association with the pathology, and we will discuss this further. Etiology क्या हो सकती है secondary dysmenorrhea की? Secondary मतलब initially the female was fine having menstrual cycles without pain, but now there is pain, right? So this is secondary dysmenorrhea. So etiology can be, मैंने जैसे कहा कि this can be a pathology associated thing, endometriosis and adenomyosis. हम इसको पढ़ेंगे डिटेल में कि what is that. Basically होता ये है कि यूट्रस में normal cycle ये है कि endometrium shed हो and the blood gets out, but sometimes in different parts there are pockets which behave like the menstrual pockets और वहाँ पे भी blood release होता है. So यहाँ पे endometrial lining होती है and the blood which comes into the uterine cavity gets out, but this then stuck and this causes pain. So endometriosis type of thing, right? There can be pelvic inflammatory disease. There can be cervical stenosis or hematometra. So there can be some pathology if there is severe pain, which is starting not from day one and suddenly recently being noticed. Secondary dysmenorrhea. Always, not always, many of the times associated with pathology, right? So like any other problem, you do the history in exam, patient will have different ideas as to what constitutes the pain. For some patient, reassurance is enough and there is no organic pathology, but sometimes there is a problem as well. And to ascertain the actual severity of the pain, the following question: do you need to take painkillers for this pain? If you do, which tablets would you prefer, or have you needed to take any time off the work? So if the pain is of that severity that they have to take routine off or they have been routinely taking painkillers, this is something serious then. Some primary dysmenorrhea is also associated with flushing and nausea, and it is important to distinguish between menstrual pain that precedes the period, which is actually a clue towards something very important, endometriosis, and pain that only occurs with the bleeding. Other important clues about etiology include pain that occurs with the passage of blood clots. So timing of the pain, इसीलिए मैं कहता हूँ history taking बहुत important है. So if somebody tells कि जी pain हो रहा है menses के साथ, so important questions to ask कि pain पहले होता है या menses के साथ ही pain शुरू होता है. This is very important. Is it only blood coming or clots coming out, right? Secondary amenorrhea may be associated with dyspareunia, painful urination, or abnormal uterine bleed. Abdominal and pelvic examination should be performed, obviously. Certain signs associated with endometriosis include a pelvic mass. You do the full examination, right? Red flags in the expression of dysmenorrhea lead the clinician to suspect serious pathology, including an abnormal cervix on examination, persistent postcoital bleed on history, intermenstrual bleed on history, and they all may indicate. So you are dealing with a person who has some pathology in the female genital tract, and you examine as we discussed in chapter number 2, right? Investigation simply, again, blood test करेंगे, transvaginal ultrasound होगा, swabs आपने लेने हैं, maybe diagnostic laparoscopy sometime. You have to investigate the cause. कि जी, where is the problem, right? There can be endometriosis anywhere. You have to take swabs. Sometimes you have to do biopsies and stuff. So maybe a diagnostic laparoscopy. You can do laparoscopy and see and explore what is wrong, where it is wrong. Discussion about laparoscopy should include the risk and possibility because this is kind of a minimally invasive surgical procedure, but you need to tell the patient what are the complications. Particularly if you are dealing with a gynecological patient, you should be telling them the risk of future fibrosis and ectopic pregnancies and all those sort of things, right? How do you manage these patients? Pain अगर simple है and there is no real organic pathology, then NSAIDs, they are very effective. Ibuprofen, naproxen, mefenamic acid, pretty effective. You can use hormonal contraceptives and they are widely used, but surprisingly, a recent review of randomized controlled trial provide little evidence supporting this treatment. So that's kind of now backing off. LNG IUS, which is used, अभी मैंने ऊपर बताया था, for HMB, there is evidence that this is beneficial for dysmenorrhea as well. Lifestyle changes, some evidence suggests that low-fat diet, more vegetarian, improves the pain. Heat, although this may seem a rather old-fashioned method, helping dysmenorrhea, but is still used. Heat packs are used to, alleviate the pain symptoms. GnRH analogs, not the first-line treatment, remember, but maybe an option for patients who are awaiting further management such as hysterectomy, right? If the pain does not settle with GnRH analog, it is unlikely to be resolved by hysterectomy. That's the bottom line. So if somebody is waiting for uterus to be removed, for example, कोई ऐसी serious pathology है, तो we try them with GnRH. So if that doesn't work, hysterectomy perhaps is not the choice. Surgery really depends. If there is something really serious, such as endometriosis, you have to remove those packets and those patches via surgery. It can be minimally invasive, such as laparoscopy. So I think that's all about this chapter. The key learning points: HMB is one of the most frequent causes of consultation. You should know what are the symptoms and pathology for HMB, and then what are the treatments for HMB. This should, I guess, be HMB, not HMG, right? LNG, NSAIDs, ये हमने बात कर ली है सारी, right? All this we have talked about. Now, I think there will be a case. A 28-year-old woman has presented to her GP with heavy menstrual bleed of 2 years duration. She also complained of some dysmenorrhea, painful bleed, which is getting worse. On examination, there is tenderness over uterosacral ligaments. What additional features of history are important? So obviously, when you are taking history, you have to identify all the details of the pain, relationship of the pain to the periods. So for example, if the pain is coming first or is it coming with the periods, right? And you know all the history details. Every single point is important. Right. Then the next question is, what are the initial investigations? Again, it goes in the same pattern. You do the blood test, you do the radiology, you do relevant investigations such as transvaginal ultrasound, blood tests including FBC or CBC, you call it, complete blood count, or CP, complete picture. Then what is your management plan? So discuss your management plan. You would like to discuss a lot of things with the patient in history, particularly if the family is complete or not, they want to have babies or not. Maybe laparoscopy, maybe diagnostic laparoscopy. If you are suspecting endometriosis, it all depends upon how the history goes, and then you decide if you have to do medical treatment or surgical treatment. Okay, but do solve these questions because they then allow you to think that if you are going in the right direction or not. Now we have a 47-year-old woman presenting to her GP with symptoms of heavy menstrual bleed with flooding and clots. So clots and flooding, what's out of blood. She's otherwise well. Examination reveals a non-tender uterus. It's not enlarged. A full blood count has shown the signs of reduced hemoglobin. Obviously, there is a lot of blood being lost. What investigation is indicated next according to the NICE guidelines, perhaps, right? So what would you do? So thyroid function test, she is otherwise normal. यहाँ पे एक वर्ड इन्होंने यूज किया था ना, thyroid patient would not have been otherwise normal. उसमें thyroid symptoms होते हैं, तो not this hormonal profile, she is otherwise normal. So you would probably do an EP hysteroscopy, okay, to see if there is malignancy, or because nothing else will tell you the gross problem, okay. A 32-year-old woman presents to her GP with regular heavy menstrual bleed. She has 2 children already and does not want more at present. This is an important point in the history. So if you have to decide for hysterectomy, for example, this gets it okay. She is medically well and has no allergies. On examination, she has a normal size uterus that is non-tender. What is the first line treatment for heavy menstrual bleed according to the NICE guideline? And first line you should know from our lecture is LNGIUS, right? So that's all about chapter number 4. I'll see you in the next chapter. So all the very best till I see you next.